Hello everyone, I welcome you to my NPTEL course titled Introduction to Medical Humanities. This is lecture 2, and in this particular lecture, I am going to define what is medical humanities. Broadly speaking, I am going to look into the major theoretical debates, one, and secondly, as to how the discipline of medical humanities came into existence globally, like who are the theorists who contributed to it primarily in terms of its medical trajectory. Before we go ahead, let me quickly take you through what the overview is like in today's session. We begin by defining medical humanities in its broader context, follow it up with the productive tensions and its effort to bridge science and lived experiences. Finally, we consider its role in professional formation, institutional critique, and its engagement with moral questions, justice, and post-colonial context. Let us briefly return to the images that I had shown you in the introduction slide. There are three images. You see figure 1, figure 2, figure 3. In figure 1, there is an empty stage. Now, this empty stage depicts a hospital bed, indicating that a patient has recently died or may be removed. The patient's body is no longer visible, yet the medical apparatus remain. What does it indicate? This indicates a prominent question on the patient's voice in the surgical or medical outcome. The second image on your screen is Cervalo's tonic in India, an advertisement that frames medicine as a commodity within colonial markets. The woman holding the bottle links health to domestic and reproductive responsibility. The man carrying a crate marked Cervalo's tonic emphasizes distribution and trade. The image, in a sense, also suggests health as purchasable and positions imported medicine as necessary within a colonial economy. The third is an important image, quite familiar with what you know of Shushruth in India, and he's an old surgeon, and this is an image from the History of Medicine collection. We can see that Shushruth is preparing to reconstruct an artificial earlobe for a mutilated patient, a procedure described in Shushruth Samhita, an early Sanskrit surgical text detailing instruments and techniques. We read this image as a reminder that medical history is not singular. It calls for a return to plural and regionally grounded histories of knowledge that predate and exceed modern Western biomedicine. In fact, in subsequent lectures, when I will take up the trajectory of medical humanities in India and try to map it with the global health, I will discuss these issues in detail as to how there was always a component of plurality in the medical sphere as far as Indian context is concerned. Now, when we define medical humanities, we can just build on these images. We adopt a very culturally grounded approach, beginning to read medical humanities as historically produced. Now, within the Indian context, as we will see throughout the course, cultural texts including literal, visual and archival have long-edged ethical questions central to medicine, authority, suffering, embodiment and care. These engagements precede the formal institutionalization of medical humanities. In terms of method, we move at two levels. At a macro level, we engage sociological and institutional analysis, and at micro level, we read cultural text and narratives to examine how medicine is represented, legitimized, and also contested. Our post-colonial framings draw on Edward Said and Ashish Nandy to question the assumed neutrality of medical knowledge. So, in Orientalism, Said demonstrates that knowledge about the Orient was constitutive. On the other hand, Nandy, in The Intimate Enemy, published in 1983, complicates the narrative further by showing that colonial modernity operated not only through institutions but through psychological and cultural internalization. Western medicine, therefore, was not passively adopted, it was negotiated and internalized in ways that reshaped both colonizer and the colonized. Borrowing from Western medical humanities are acknowledged, however, they are treated as outcomes of colonial history rather than as foundational origins. Indian medical humanities must therefore be located within what we can term as plural knowledge traditions and uneven historical exchanges. When we talk about the origin of the word, what is humanities and why does it matter, you will find that the word humanitas, articulated by Cicero, means humane feeling, but it also referred to refinement through education. Intellectual training and moral disposition were not separate domains, and therefore this concept parallels the Greek idea of philanthropia. The belief that education in the liberal arts also produces generosity towards others. In the 14th century, Petrarch reworked humanitas, and he reworked into threefold model. What was this threefold model on your screen? It was humane feeling, intellectual cultivation, and action in the civic world. This model shaped liberal education traditions and was reformulated in the 20th century by Lionel Trilling as the humanistic educational ideal. More recently, Martha Nussbaum has defended a version of this ideal, arguing that democratic societies require citizens trained in critical thinking and empathy. So, what does humanities combine? Emotion and intellect, knowledge and virtue, reflection and action. Modern academia often separates science and humanities, science as objective, measurable, technical, and humanities as interpretative, moral, subjective. But historically, humanitas did not recognize this split. Defining the humanities today is not a simple task. They can be defined by subject matter, disciplines, or methods, but no final definition is possible or perhaps even desirable. So, let us now discuss the origins of the medical humanities, in which we find that before the late 19th century, there were no major research universities or modern medical schools in the United States. Now, the physicians trained in Europe were steeped in classical humanistic education, and medical students in London, Edinburgh, Paris, Padua, and Vienna were required to read Galen and Hippocrates in Latin. History was central to professional identity. Medicine in itself was understood as a part of learned tradition. But this model began to shift. Now, what happened? Over the centuries, the humanities themselves became increasingly specialized and oriented towards pure scholarship. In the second half of the 19th century, German research universities accelerated this shift. The ethos of scientific dynamism replaced the preservation of tradition. Knowledge production began to outweigh moral cultivation. American physicians trained in German laboratories brought back a new model. This model was called medicine as experimental science. When Johns Hopkins Medical School opened in 1893, modeled on Germany, biomedical science rapidly displaced older humanistic frameworks as the model of medical authority. Yet, even at that moment of scientific triumph, there was concern. Concern was about excessive specialization, reductionist thinking, commercialism, and moral drift. In short, they were worried about dehumanization. Figures such as William Osler and John Shaw Billings attempted to preserve medicine's moral center. Osler argued that medicine was more than an art and a science, a calling rather than a business. It required education of the heart as well as the head. Now, this anxiety towards this dehumanization process started to intensify in the earlier 20th century, because in 1929, at John Hopkins, Harvey Cushing declared, and I quote, "Medicine has become so scattered and subdivided that there is a crying need for someone to lead it from the wilderness and bind it together." Therefore, medicine in its early form emerged as a response to fragmentation, and history became a tool through which medicine sought coherence and moral grounding. But early medical humanities has limits. And what is the limit? The limit is that emphasized cultivation and elite formation. It was largely white, male, upper class. The whole epistemology relied on great men's version of history, and therefore it was insufficiently critical and often nostalgic rather than analytically rigorous. Medical humanities thus began not as a critique but as a restoration, an attempt to prevent science and commerce from taking out the soul of the medicine. And in this regard, you will find Pellegrino's model extremely relevant because he redefined the field. And there are three things that we have to remember. On your screen, clarify ethical values in clinical practice, cultivate critical self-examination, educate and not merely train. These were the three agendas he set in terms of redefining the role of humanities. Let us go one by one. Now, in the first place, when he was talking about clarifying ethical values in clinical practice, he meant that clinical decisions always involve judgment. Judgment about risk, consent, responsibility, and justice. So, Pellegrino helped institutionalize this concern through the development of bioethics in the 1980s, a term that we will discuss in lecture 3 when we are discussing the keywords. In fact, bioethics is the first word we will begin with. Secondly, the humanities must cultivate critical self-examination. This meant that physicians must question their assumptions, recognize institutional pressures, and examine how authority operates in practice. The third was around the training procedure, and it said that humanities must confer those attitudes which distinguish the educated from the merely trained. Training produces technical skill, the education produces discernment. Pellegrino retained part of the older humanities ideal, integration of knowledge, compassion, and action, but he modernized it. He acknowledged that contemporary medicine cannot just rely on very scientific cultivation. It requires structural collaborations with scholars in ethics, history, and philosophy. When we discuss medical humanities as a field or discipline, we use the term medical humanities, but we don't know. So, the field draws from different disciplines: history, literature, philosophy, religious studies, anthropology, sociology, and the arts. Now, the breadth raises an important question. Should we understand medical humanities as a discipline with its own fixed method and boundaries, a discipline typically claiming to be with methodological coherence and institutional autonomy, a field often operating more flexibly, borrowing tools and framework from elsewhere? A related debate concerns whether medical humanities is multidisciplinary or interdisciplinary. We will not resolve this definitely here, but it seems productive to approach medical humanities as a field that operate both ways, sometimes juxtaposing perspectives, sometimes interrogating them. What may distinguish medical humanities, however, is its practical orientation. The knowledge it produces does not remain abstract. It often bears directly on ethical care, professional formation, medical education, public health practice. So, rather than giving it a very fixed kind of a definition, we can treat medical humanities as a dynamic field, one that gathers methods across the humanities and social sciences domain to examine medicine into practice, institution, and cultural force. Now, the problem of exclusivity and hierarchy is pretty much embedded in the medical humanities domain. Critics argue that the term can sound hierarchical because it may unintentionally center doctors while marginalizing nurses, dentists, public health workers, and others. For this reason, several scholars propose the term health humanities, a distinction that I want to kind of begin and end here. This course is all about medical humanities. I take up health issues, but I do not deal with health humanities because that is a more inclusive term. Health humanities suggests that it attempts to place all health professionals on equal conceptual ground. So, we see this impulse in journal titles such as the Cambridge Quarterly of Healthcare Ethics, which adopts a broader framing rather than medical ethics. In recent years, figures such as Paul Crawford has actively advanced the intellectual and institutional case for health humanities. Similarly, Theresa Jones, Dalis Weir, and Lester D. Friedman titled their 2014 collection, The Health Humanities Reader, signaling this broader orientation. At the same time, some scholars retain the term medical humanities. Why? Partly because much of the existing scholarship still centers on medicine. Partly because scope matters. A given text or course may focus primarily on medicine, even while acknowledging public health and non-allopathic traditions. Perhaps the more productive stance is not to treat the terminology as fixed, but to remain alert to its politics. If we retain medical humanities, we do so critically, aware of power, hierarchy, and professional dominance, and prepared to examine these issues within the field itself. So, to clarify the aims of medical humanities, it helps us to look at how the field has been conceptualized. Let us see here. In medicine and the humanities, theoretical and methodological issues, Raimo Pustin, Michael Lehman, and Anna Maria Viljanen identify a major shift in clinical medicine over the past 50 years. What do they observe? They observe that the biological approach alone cannot address the various human phenomena that physicians encounter in everyday practice. Now, this marks a movement away from what you can term as medical reductionism towards medical holism. Patients are no longer viewed merely as diseased bodies. They are understood as persons embedded in relationships, histories, and context. Several thinkers shaped this shift. You can see here we have George Angel, who discussed biopsychosocial model, Eric Castle, who talked about personhood and suffering, Edmund Pellegrino and David Thomasa, who discussed philosophy of medicine, and we have Christina Puchalski, who discussed spiritual care. So, medical humanities at that point of time started to face criticism, and we find that by the 1960s, students and reformers questioned the dominance of strictly biomedical curriculum. Therefore, we will examine these goals critically and consider whether a fourth explicitly normal and political aim must also be acknowledged. So, in 1980, when George Angel challenged the operations of clinical medicine within a narrow biomedical frame, he proposed the biopsychosocial framework. Now, this framework insisted that clinical medicine is not only biological but also psychological and social. When I analyze the literary and cultural text, this is the model that I am going to employ. So, you must read a little more on this before you come for the analysis, say somewhere around week 6 or 7. Now, in his view, health and illness cannot be understood solely from laboratory data. They require attention to lived experiences and social context. In 1991, Eric Castle extended this move by distinguishing between pain and suffering. As he argued, bodies feel pain, but persons suffer. This shift legitimized forms of data that biomedicine alone cannot capture, and therefore the distinction between disease and illness further clarifies this bridge. Very succinctly, I will talk about disease and illness. So, disease refers to the biological pathology and illness refers to the lived experience. I will go about these two terms in detail in my lecture 3, where I discuss the keywords to understand the medical humanities. But other practices reinforce this bridge, in which reading illness narratives and pathographies, or watching films or theatrical representation of illness, or studying visual art that depicts pain embodiment were seen as a model of recovery. But a final question remained open. What is that? Should medical humanities integrate science and the humanities into a unified framework, or does it simply add humanities content onto a large scientific curriculum? For the time, medical educators assumed that teaching ethic courses would naturally strengthen ethical behavior. That assumption proved fragile. Jack Culhan identifies several pressures that reshaped this conversation. First, the expansion of expensive medical technologies, and you will see that so many are listed here: CT, MRI, high cost diagnostic, and other tools as well. Now, second, patients express dissatisfaction because technology could prolong biological life while extending suffering. Third, the rise of commercialism altered the moral landscape of medicine. For profit, hospitals, managed care systems, and relationships with pharmaceutical and biotech companies introduced new and visible conflicts of interest. A profession, at least in principle, is grounded in altruism and fiduciary responsibility. Yet, physicians now operate within institutional and economic pressures that complicate these ideals. Medical humanities responds by cultivating virtues, altruism, empathy, compassion, and by developing reflective and critical habits of mind. It also acknowledges a further dimension. Educating human physicians includes creating space for self-care. Without that, compassion may erode under systemic strain. The question then is not simply whether the humanities make physician humane, it is how they help professionals navigate the modern complexity of the contemporary medicine. When we think of medical humanities as a function of moral critique, we find that recent global discussions on physician burnout and suicide, including reflections such as those by Lisa Pryor and epidemiological studies like Abdul Aziz Alosaima et al., expose deep stress within medical culture. Training demands near total commitment, and yet institutional structures often fail to provide adequate psychological or structural support. A culture that valorizes perfectionism and grit may appear admirable, but it also can conceal dysfunction. To become learned, one must also become critical and self-critical. Medical humanities therefore extends beyond the cultivation of sympathy or empathy. As some scholars put it, the field observes moral critique and political aspiration. Historically, medical humanities developed alongside patient rights movement of the 1960s and 1970s and remained attentive to how knowledge is produced, used and distributed, and whose interest it serves. In this sense, the field started by interrogating what is understood by humanizing medicine. If we step back, medical humanities can be described across three broad overlapping domains. One, context; the other, conceptual analysis; and third is formation. So, to study the context is to situate medicine historically, culturally, economically, and politically. It asks how medicine is practiced in different systems. For example, under the National Health Service in the United Kingdom versus in the National Medical Commission in India, how are the differences? It asks whether the Hippocratic Oath emerged and whose interest it served. It asked how medieval Christianity shaped European understanding of disease and how Buddhist view of suffering inform ideas of health. Secondly, when we think of conceptual and critical analysis, what distinguishes disease from illness or curing from healing? What are the goals of medicine? Conceptual analysis often exposes instability. Conditions such as alcoholism or attention deficit hyperactivity disorder, for instance, may shift, being framed as pathology and as forms of normal human variation. Third, we talk about medical humanities also becomes pedagogy, how professionals are shaped. What is now termed professional identity formation echoes older traditions of humanitas, the formation of persons who combine knowledge, compassion, and action. Medicine, in this view, is not merely technical, and physicians are not plumbers of the body. They are witness to suffering, to flourishing, and to their own moral limits. Finally, we come to the post-colonial context and how there is a narrative dislocation, but before that, a caution. And on your screen, as Euro Yengesteron warns, medicine risks regressing to a purely instrumental biomedical baseline, choking the potential release of its metaphoric hoard as possibility knowledge. The expansion towards ethical, aesthetic, political, and even transcendental dimensions does not weaken science. If we synthesize these strands, medical humanities emerges not as a decorative supplement to medicine, but as a mode of inquiry that situates, clarifies, critiques, and forms. And in doing so, it continuously asks what medicine is and what it ought to become. If we end where we began, with narratives, we see that the person seeking care rarely seeks biology alone. Literary texts show individuals pursuing recognition, dignity, and alignment between treatment and their own moral worlds. Those worlds do not always conform to dominant Western ethical standards. They may draw on practices labeled traditional, local, or even irrational. A post-colonial perspectives shifts the perspective. What does it do? It asks us to pause before accepting such labels. It questions who defines the standard, who decides what counts as legitimate knowledge, whose practices become central, and whose are relegated to the margins. Medical humanities, when situated critically, asks how medicine looks when we take seriously multiple epistemologies, multiple moral vocabularies, and multiple histories. In a post-colonial frames, these strands converge. Medical humanities becomes a space where medicine is not only humanized but destabilized, only to be reimagined, reconceptualized, and refigured. Thank you so much. In the next slide, we begin with the key terms to be used in medical humanities and follow it up with key theorists. I'll see you in the next slide. Thank you so much.